So without further ado, I want to turn it over to Janusz.
Well, good morning, everyone. I don't know how many people are joining, but ideally, I would like to keep it interactive. So one possibility is that I present first. If you have any issues, you can raise your hand, you can write your comments, and perhaps we can have sort of more open discussion towards the end of my presentation. So as indicated by Robert, my name is Janusz Kaczorowski. I'm a professor and research director in the Department of Family and Emergency Medicine at the University of Montreal, and also a senior scientist at the Research Center of the Hospital of University of Montreal. And I'll be talking about cluster randomized controlled trials. So this is briefly just the outline of my presentation. We're going to cover the issues of what are cluster RCTs, why and when do we use them, some special considerations pertaining to sample size, power calculations, some special considerations with respect to design issues, some opportunities or different approaches in terms of how data from those types of studies can be analyzed. And we're also going to touch on some special ethical considerations as they apply to cluster RCTs. So really sort of a very simple definition of a cluster RCT is that instead of randomly allocating individuals, as we do in most sort of classical clinical trials, we are actually randomizing social units or clusters. So examples of that might be randomizing communities, randomizing schools or classes within schools, full families as opposed to individual members, clinics or practices. So it might be family health team, it might be a solo practitioner, it might be a community pharmacy. And this type of design is increasingly used in health technology assessment studies. And I'll sort of explain to you why and what are sort of the advantages and disadvantages of using that type of methodology. So again, rather than individuals, we are randomizing units. And this is, very frequently considered when we have sort of several different issues that we have to address. So probably the primary one is potential contamination. So imagine that you have developed an intervention to say prevent coronary risk factors. Now, if you have individual level randomization, it would be possible that people who are allocated to the intervention and to the control group, if they are within the same practice or within the same family, can actually share information about this, about the intervention, and by doing so, contaminate your study. Frequently, we're also looking at feasibility considerations. If we were to design an intervention, for example, that targets physicians to improve adherence to guidelines around hypertension and screening and management, it would be very difficult for the physician to basically turn on and off the knowledge that they have just acquired. So imagine that we provided them with a toolkit, with updated summary guidelines. Again, it would be difficult for the physician to use this information on intervention patients and then to sort of unlearn and pretend that that information is no longer available when they deal with a control patient. And there are some situations where this is really the only natural choice available. So imagine that your intervention is a community-wide mass media campaign. Again, it would be very difficult for you to imagine that if you using mass media or social media, that you can target some members of the community and not the others. So here the natural choice would be that everyone within the community is essentially targeted as part of your intervention. So again, instead of individuals as we had before, you can see that we have clusters. So here we have 4 clusters in the intervention group, 4 in the control group, and each of the clusters here contains 4 individuals. So some of the examples of the type of intervention and the type of cluster or social unit that you would consider is provided in this table. So say your intervention is around implementation of the latest guidelines. And then really the people that you are targeting are general practitioners or family medicine practices, again, with the hope that that information is going to be applied at the level of individual patients, but you're really targeting physicians with the information. As I mentioned before, if you contemplating mass media campaign, then probably the natural unit would be a community. And again, depending on the type of media, it might be even larger than that. You might be looking at regions or maybe even provinces or states. Another example, smoking prevention intervention. You might be targeting schools or grades within individual schools. Dietary intervention is an interesting one because a lot of times every member of the family would be exposed to the same diet. So again, it makes a lot of sense that your intervention would be really targeting the sort of the full household as opposed to just one individual from that family. And these are some of the examples of studies that I have participated in, utilizing really different units of randomization. So some of them utilized communities. So 2 of the trials utilized communities. One was improving the immunization in rural communities in British Columbia, where we were targeting communities of around 5,000 individuals. Another study, which was 39 community study, involved 39 communities of between 10 and 60,000 individuals in Ontario, and half of the communities were controls and half of the communities were intervention communities. On the left-hand side, you have examples of 2 other studies, both of those targeting family physicians, family practices as the primary unit. So again, the idea was that the intervention was really sort of at the practice level, but the impact of that intervention was measured at the patient level. So some of the challenges associated with the cluster RCT is really essentially a statistical consideration that normally most of our statistical tests have certain assumptions, the assumptions of normal distribution, and the one which is really pertinent and important in this context is that our units are independent, meaning that if we do a random allocation and then if we conduct statistical analysis, we assume that all the units that we are analyzing are independent from one another. But this is not true when you're looking at clusters, and this is sort of the famous notion of the clustering effect, because people within the same group tend to share certain characteristics. Just to give you an example, if you're targeting patients attending a particular practice, they have probably at least 2 sort of different things that make them more similar than patients from another practice. The first one, of course, is the physician or the health professional team that they receive care from. So this is sort of something that they have in common, and that individual might have a special focus or special approach when dealing with certain conditions or with certain issues. The second level is that practices tend to cater to individuals with different socioeconomic status. So simply by the virtue of geographical location, patients might be of a higher socioeconomic status who attend one practice versus patients attending a different practice. And this lack of independence influences both the design and analysis of cluster RCTs. And really what that means is that the standard approaches to how we calculate sample size, how we analyze the data, don't apply to cluster RCTs. And inevitably, the impact is that if you don't take the clustering into account, you're going to end up with a study that's underpowered. So it's never going in the direction of having a study that's overpowered. It's always going to basically dilute your power and make your power less powerful. And really what that means is that you're sort of increasing the likelihood of either arriving at spurious results or really not being sufficiently powered to properly test the hypothesis of interest. So in order to do that, the sample size calculations for cluster RCTs have to take that clustering issue into account and basically inflate the sample size in order to maintain the same statistical power. And again, we're going to look at some of the issues that really apply to any design of a randomized trial and power calculations. So just like in any other study, we have to decide what is our primary outcome, what are some of the secondary outcomes, and normally our studies ought to be powered to test properly our primary study outcomes. So you might have 5 or 6 different things that you plan to measure, but your power calculations ought to be based on your primary endpoint or primary study outcome. The second thing that's again applicable to any design is really sort of deciding what is the effect size. So by how much do we anticipate a particular intervention to improve the outcome of interest? And this is frequently referred to as sort of clinical significance. So this is not just about statistical significance, it's really about clinical significance. And one way of approaching it is really sort of deciding what would be the smallest difference that would justify a change in how we currently do things. And as you can imagine, that would differ depending on what is our outcome, what is our intervention. So sometimes you might be interested in a fairly large difference. Sometimes a fairly small difference in terms of absolute terms would be of interest. Again, makes a lot of sense for you to decide a priori what kind of statistical test you're planning to utilize and to what extent your hypothesis is one-sided or two-sided. Most of the RCTs nowadays are probably two-sided, although the implication is that you actually require larger sample size. One-sided hypothesis means there is a direction to your hypothesis. So you are only interested in detecting an improvement. And when you have a two-sided hypothesis, basically you are powering your studies to detect a difference. And that difference might be in direction positive or negative with respect to your primary hypothesis. In cluster RCTs, you have to make a couple of additional decisions. You have to decide how many clusters you're going to have and what is going to be the size of each of your clusters. And those two pieces of information are very important because they help you to decide by how much do you need to inflate or adjust your sample size calculations. And another very important piece of information is that intercluster correlation. And we're going to sort of go over what that is and how do you estimate that. As I mentioned before, the intercluster correlation coefficient, or ICC as it's frequently referred to, basically means that there are two components to variation. That is, to what extent individuals from within the same cluster are alike relative to individuals from other clusters. So you have essentially the within cluster variability and between cluster variability. And these two components can be estimated by utilizing different methodologies. One of them is intercluster correlation coefficient. The other one, a similar concept, is the coefficient of variation between clusters. And just to give you an example, and again, it sometimes sounds like a little bit like a magic, but it's not. It's actually fairly straightforward. So the ICC or rho is really the measure of the degree of similarity or correlation of responses within a given cluster. And that value can range from 0 to 1. If you have a value of 0, it means that people from the same cluster are really not different than people from any other cluster. So there is really no dependency, and you don't really have to worry about the clustering effect. If you have a value of 1, it means that there is a perfect correlation, meaning that simply by knowing which cluster someone belongs to, you can actually tell what score or what value that individual would have with respect to your variable of interest. And a fairly simple way of estimating ICC, and now there is SPSS and SAS, and most of the statistical packages would actually have an option of calculating intercluster correlation coefficient. But just sort of to give you an idea, what are the components of it? If you were to run a simple one-way analysis of variance on your dependent variable, the ANOVA would provide you with the information on what is the between cluster and within cluster correlate variance. And those two pieces of information would allow you to calculate intercluster correlation. And this piece of information is important for you because this is what you would use in order to decide by how much do you need to inflate your sample size in order to maintain the original power that you wanted to have to test your hypothesis. And this is frequently referred to as a design effect, and it's really a value of 1 plus intercluster correlation or rho multiplied by m, which is the cluster size minus 1. And I'm going to provide you with an example. So again, we're going to demystify a little bit what it is and how it operates. So imagine that you sort of designing a randomized trial, and you hypothesize that your intervention is going to be result in a 20% higher response rate to a treatment in the intervention group than in the control group. So say the standard response is 40%. So 40% of patients would get better if you use sort of the routine approach to treating a particular condition. Now you have come up with a new treatment, and you think that that new treatment is going to be at least 20% more effective. And really, we talk here in absolute terms. So this is not a relative improvement. You're really looking at a difference of 40% of people getting better versus 60% of people getting better. And if this was an individual or classical clinical trial, you would simply use one of the existing power calculations. You're really looking at the difference between 40% versus 60% rate. And a lot of people would use standard criteria. So usually power of 80% or higher is what's desired. A lot of people would use two-sided alpha because your hypothesis is bidirectional. So even though you want to test the improvement, really here we are talking about a 20% difference. Okay, so the difference can go either way. And if you plug in those numbers into standard sample size calculation, it would tell you that you need 107 individuals per group. So your sample size for the trial to detect a difference of 20% would require a total of 214 individuals. Now imagine that those 214 individuals are recruited from 20 different clinics or 20 different pharmacies or 20 different units that you are interested in, with approximately 10 subjects per clinic. So again, 10 subjects multiplied by 20 clinics, that gives you around 200 individuals. And let's imagine that the intercluster correlation is of 0.01. So not very high, but not very low either. Okay, like correlation of 0.1. So if we were to apply the formula for the design effect to those numbers, we are getting a value of 1.9. And that value of 1.9 really tells us by how much do we need to increase our sample size in order to maintain the original power. So in order to detect a 20% difference with the same power, two-sided alpha, instead of using 214 individuals, we need a sample size of 214 multiplied by 1.9, which really means that we have to increase our sample size by around 90%. So if you look at the next slide, what that means is that the new sample size is really 214 multiplied by design effect, which was 1.9, which gives us a new sample size of 407 individuals. And let's assume in this example that we are holding the cluster size constant, meaning that we are still recruiting 10 subjects per practice or 10 subjects per pharmacy. So in order to maintain the same power as what we originally anticipated, we would have to increase the number of clusters or practices from approximately 20, as we had it before, to 40, and that's still recruiting approximately 10 patients from each in order to have the same power. Now, what's important to note is that you're really gaining power by increasing the number of clusters. You don't really increase the power by increasing the number of individuals per cluster. So, alternatively, you could say, why not just recruit 20 patients per cluster from the same original 20 practices? Well, yes, you would improve your power somewhat, but you would still fall short precisely because of that intercluster correlation. In most situations, increasing the cluster size beyond 100 subjects really doesn't provide you much in terms of statistical gain. So you're not really improving the power by going beyond a cluster of 100. And it's always, a somewhat pragmatic decision because you have to really find what's feasible and what's realistic in terms of balancing the number of clusters and the size of clusters. As the number of clusters increases, power increases, but increasing the size of clusters has actually little impact on your power. And you can never get rid of clustering effects simply by increasing the number of individuals per cluster. Okay? It's just not going to help you very much. Of course, if the clusters are very small, the clustering effect has much less impact on the overall power, even if ICC is substantial. So going back to our original example of detecting that 20% difference that required 214 subjects, if we were to include only one patient per practice, so we would have to have a total of 214 practices, and each one would supply one patient. Basically, we don't have to worry about intercluster correlation. It does not exist. But of course, if you look at practical considerations, it's much easier to recruit more patients per practice than to recruit that many practices. And again, the issue here is that the intervention that you have in mind is really targeting the healthcare professional, but the effectiveness of that intervention is actually assessed at the patient level. So here you have some examples of what happens to sort of the total number of cases that you need based on how many physicians you have and how many patients you have per physician. So on the left-hand side, you can see sort of the number of physicians increasing from 4 to 8, 16, 32, 64, all the way to 128, and then the number of patients in the next column. So you can see that the number of sort of total number of subjects in this particular example remains constant. You have 128, but they are recruited from fewer or from larger number of practices. And the intercluster correlation is held constant here at 0.017. And you can see the design effect, how it changes from around 1.5 all the way to 1, basically not existent. But you can also see the impact on the power that that would have, depending on which decision you made in terms of either increasing the number of patients or increasing the number of physicians. Continuing with sort of a similar example, again, just to give you an idea in terms of what happens if you hold different things constant. So again, the intercluster correlation stays the same in this example. In the table 2, you can see that the number of physicians stays the same. So we only have 4 physicians, but we play with the number of patients which are recruited from each of those practices. And you can see that the power of the test changes quite significantly. Sort of the last column on the right, really from very underpowered study with a power of 29 all the way to a study that's very powerful with a power of 82. And then the table 3 tells you what's happening if you hold constant the number of patients, but you're increasing the number of clusters or number of physicians, again, holding the intercluster correlation or rho constant in that example. So as I mentioned before, you have to make some pragmatic decisions in terms of what's available, what's feasible, and what is a realistic balance between the number of clusters and participants within each cluster. It is, again, like for any sample size calculation, very important for you to have some idea as to how the outcome of interest is distributed, be it in terms of proportion, in terms of mean, median, what is the variability of your outcome. So if you have a measure of standard error, standard deviation, that's very, very useful. Again, as for any study, you have to sort of decide what is that minimum effect size that you are interested in detecting, and then what is the intercluster correlation coefficient, because you would require this piece of information in order to make appropriate estimates of your sample size. Now, you're probably wondering, well, where do I find estimates for ICC? So, of course, as usual, having some pilot data is always a good idea. And if you ever contemplating applying to conduct a randomized control trial, be it cluster RCT or just a classical RCT, I would say that one of the main reasons why even really good questions, really good interventions are not being funded, because people question feasibility. And they always worry that you might run into more problems in terms of recruiting patients. There's a paradox that's well known, that usually the prevalence of the disease is very high when you write in the research protocol, and it tends to significantly reduce once you actually start recruiting patients for the trial. So a lot of even very good protocols get rejected because the reviewers look at what you are proposing, and usually the biggest concern is really, is this really feasible? Can you actually do it? And in that context, having some pilot data demonstrating what is your recruitment rates, how many of the eligible people you can actually identify, what is the time required to recruit sufficient number of practices, sufficient number of patients? What is the attrition rate? How is your intervention being implemented? What is the fidelity of implementing it? And what is the distribution in terms of how people respond to your intervention? So pilot data is always extremely useful because it really helps to convince the reviewers that your study not only is based on good hypothesis and good literature review and all that, but it is actually implementable, that you can actually implement it. And of course, pilot data is very useful in terms of allowing you to see to what extent intercluster correlation is an issue. Part of the problem, of course, is that usually in order to get estimates which are reasonably stable and valid, you would probably need around 20 clusters. So it's almost like doing a full study in order to have a good estimate. But I would say that having a pilot that involves even 2 or 3 clusters would go a long way to convince the reviewers that your sample size calculations and your clustering effect is taken into account as far as your methods are concerned. Sometimes you can use baseline data from your study, but most of the time that's probably too late, and it'll be very difficult for you to receive funding, say from CIHR, if you didn't really specify what is the desired, the ultimate sample size that you need in order to properly test your hypothesis. You can also look at published estimates. So increasingly, there are individuals who, in a fairly routine manner, publish estimates of intercluster correlations around key outcomes from settings that might be of interest to researchers, such as family physicians or family health teams, community pharmacies, or even estimates at the community level. And if all else fails, of course, you can always defer to your best guess in terms of what that intercluster correlation might be. This is some examples. So again, if you sort of do lit search, chances are that you might find some idea in terms of what you are looking at. So this is from a paper published in 2004, basically looking at number of problems per 100 encounters derived from a sample of over 1,000 GPs. And you can see that the ICCs are not, for certain things, are fairly small, but again, depending on the cluster size, even a relatively small ICC will have a significant impact on your study design. Here's some more. This is actually one of the studies that we did, and again, you can see that there is a fair bit of variability. Generally speaking, the variables which are under control of the physician, sort of the process measures, would tend to have higher ICCs, because basically the same physician looking after the practice would tend to sort of utilize the same approach across a whole range of patients nested within his practice. So here you can see that for systolic blood pressure, I think we have the highest ICC of almost 0.2, fairly significant, meaning that some physicians are probably much more aggressive in terms of how they treat systolic blood pressure. So the patients from that practice would have better control of systolic blood pressure than patients from other practices. I think that the highest intercluster correlation coefficient I have seen was almost 0.7, and that was again a physician-driven variable, which was X-ray exam for smokers. And as you probably know, this is not necessarily something that's recommended by the guidelines, but what that means is that there were some physicians who would basically do it on older smokers, and there would be some physicians that would be doing it on none of their smokers. And that's why you had such a large intercluster correlation, because what it meant is that simply by knowing which practice a particular patient was attending, if that patient was a smoker, you would have a fairly high level of certitude if that patient was ever screened or not screened for lung cancer using an X-ray methodology. So this is sort of an extreme example. Um, there is a very good and growing database of intercluster correlations, a lot of them from studies involving primary care settings, pharmacies, family practices, and that's at the University of Aberdeen in Scotland. And you have a link here. In fact, that site contains quite a lot of information around cluster RCTs, including power calculation calculator, and also a spreadsheet or database with a fairly large number of ICCs, so giving the information on where the data is coming from, how large were the clusters, what was the distribution before, after the intervention, and so forth. Generally speaking, in primary care, most of the ICCs would range from 0.01 to 0.05 for outcomes, and they would tend to be higher for processes which are more under control of the physician or attending healthcare professional, and those would tend to range from 0.05 to 0.15. But again, there are some examples where those values can be higher. So, again, you have to sort of ask yourself a question, to what extent you expect that the outcome that you are interested in is likely to have more of that clustering effect. Again, some of the design issues, and again, this is probably not all that different from designing any RCT, but you have to sort of, first of all, take into account the fact that you are randomizing at the cluster level. So all the subjects within a given cluster will be allocated to the same arm. And because usually the number of clusters is usually relatively small with that type of design, randomization itself tends to be less efficient than if you're dealing with individual level randomization. And what that means is that you have sort of some choices in terms of making sure that your randomization is as efficient as possible, meaning that you're ending up with groups which are as comparable as possible with respect to everything except for the intervention itself. So you can go for the just sort of simple randomization with any restrictions, but a lot of times people would utilize some type of restricted approach to randomization, and stratification and matched pairs are sort of two of the examples. So again, stratification is also utilized in sort of classical RCTs, but it's probably of particular relevance in cluster RCTs precisely because of the small number of clusters. So the efficiency of randomization sort of doesn't demonstrate itself to the same extent because you're frequently dealing with maybe 30, 40, 50 clusters. So it's not as efficient as if you're dealing with 600 or 700 or a few thousand individuals. So some of the things that you might consider as a stratifying factor might be, of course, the cluster site itself. So sometimes you have clusters by design which are of equal size, but sometimes they differ quite a bit. So to give you an example of the study that we did with 39 communities in Ontario, we actually decided to stratify our randomization by community size. So we wanted to have similar number of smaller communities in the intervention and the control group, and a similar number of larger communities in the control and in the intervention communities. We were also concerned about geography, that communities in the north were probably different from those in the south. So we also stratified randomization by geographical location. There is still a fair bit of debate within scientific or methodological community to what extent strata itself should be subsequently modeled as fixed or as random effect in your statistical analysis. Pair matching used to be fairly popular at one time. I think that there are very few people who are doing it nowadays. But what you're trying to do is you actually matching as much as possible units of interest, and then within each pair you randomly allocate one of them to intervention and one of them to control. The main disadvantage is that if you lose one unit, you're losing the full pair, because this is how your analysis was designed. And in terms of statistical analysis, you have much less options in terms of what you can do with that type of approach. So this used to be fairly popular sort of in the early days of cluster randomized trials, and I think that nowadays there are very, very few people who utilize that approach. One of the sort of issues to consider is what's called post-randomization recruitment bias. Because a lot of times it is after randomization of units that the recruitment of individual patients or subjects begins. And of course, that introduces the possibility that you're going to have bias, because the person who is recruiting the participants knows that those patients are going to be in the control group, or those patients going to be the intervention group, and that inevitably is going to influence who is being approached and who is being ultimately enrolled into the study. One potential solution, of course, is that you recruit clusters and individuals within these clusters, and only then do your randomization. Some other design issues have to do with concealment and blinding. So this is really about sort of allocation, your random allocation. Again, because you're dealing with a relatively small number of clusters, my sort of advice would be that the randomization itself is really conducted by someone who is independent of the trial. Say you're only dealing with 20 or 30 clusters, if it's a member of the research team that's doing that, I think that sort of the likelihood that they might influence sort of the concealment process is fairly high. So one strategy is, just get someone independent of your study to do that concealed allocation. Of course, the blinding is virtually impossible in cluster RCTs, and a lot of people would raise concerns about validity, but this is just sort of the nature of the beast. It's virtually impossible to maintain it in cluster RCTs, again, depending on what is your cluster. You can probably do it at the community level. If you're doing it at the practice level and you're collecting information from individual patients and individual physicians, of course, people would likely guess whether they belong to the intervention or to the control group. Probably the most important issue, and this is true with every RCT, that at the very least you should make sure that people who are assessing the primary outcome of interest are blinded to the allocation group, so they don't know if the patients or practices belong to the intervention or to the control group. And as with all RCTs, you normally need to have not only your RCT registered in order to get it published, but you should also follow the consort statement. And in fact, there is a special version of consort statement that was designed specifically for cluster RCTs. And I'm going to sort of show you how that looks like.
Janusz, I just wanted to give you a heads up. It's about a 15-minute warning here that we have left.
Okay, so I'll try to wrap it up within the next 5 minutes or so. So the extension of the consort for cluster RCTs is that you should provide the rationale as to why you believe that your hypothesis would be best tested using the cluster design. How the clustering was incorporated into your sample size calculations, how was that incorporated in your analysis, and you have to show the flow of both clusters and individuals throughout the trial, from the time that they were assigned all the way to the analysis. And you can actually find sort of the full extended consort statement in BMJ. It was published by Campbell in 2004. And it's also available on the consort webpage. So this is just an example where you're actually sort of showing the information both at individual and cluster level. So on the top, you have information at the cluster level, and at the bottom, you have intervention. You have sort of the same information at the patient level, and sort of similar example, sort of showing you sort of your statistics based on without adjustment for clustering and with adjustment for clustering, and you can see how the information changes based on that adjustment. And this is sort of the extended consort, which is sort of showing you firstly the flow, the study flow based on clusters, followed by the same sort of idea, but showing the individual practices and individual patients in terms of how they flow through your study. In terms of analyzing your data, you have a number of different options. Probably the simplest one is sort of weighted or just regular t-test at the cluster level. So you average the data for all individuals within the same cluster, and then basically each cluster has just one value, and then you conduct the t-test to compare the intervention clusters with the control clusters. And you have variety of patient level analysis where you can adjust your statistics. So there's a chi-square adjustment for clustering, the t-test, the f-test, and so forth. Although increasingly people are really moving towards sort of more sophisticated approaches that allow you mixed linear modeling, and probably generalized estimating equations are sort of the most popular approaches that are currently utilized to analyze the cluster RCTs. And those types of analysis basically allow you to make adjustments for clustering. So your p-values and your confidence intervals are adjusted based on clustering within your study. I'm not going to really go over the t-test because I think that this is probably one of the least efficient way of doing it. It can be done. It used to be done quite a bit, again, maybe 15, 20 years ago, but it's not really done because it's just statistically not very efficient. You know, say you had 200 patients from 20 practices, your t-test is ultimately based on the n of 20 and not the n of 200. So you're really losing a lot of power as a result of doing that. Those are sort of the different adjustments for the sort of chi-square tests and t-tests. And again, a lot of those are available in standard statistical packages, but usually you have to specifically ask for them, okay? But those are sort of examples of tests that you could do that would be automatically adjusted for the clustering effect. And of course, your data itself has to be organized to reflect the clustering. So normally it has to be explicitly designed in your database that the patients are nested within practices, or whatever was sort of the unit of randomization that you have utilized, because that is the information that is utilized in order to make that adjustment for clustering. The meta-analysis approach, again, only is used for the paired cluster RCTs. And again, not a lot of people are using it nowadays. It basically resembles what people would do in meta-analysis, because you basically looking at pairs of communities, for example, and you're estimating the effect for each of them, and then you have a summary statistic which looks sort of at the overall picture once you take that into account. And as I mentioned, this is probably sort of the approach that's utilized most frequently, which is really an extension of logistic regression that adjusts for clustering. It does not require parametric assumptions, which is very good, which means that it's very robust. Tests odds ratio of intervention effect and can adjust for individual and cluster level covariates. It is probably normally something that requires at least or approximately 40 clusters in order to be valid. But the correlation structure and sort of statistical performance is fairly robust. So it's probably the preferred method of analyzing those types of trials. And then you have again some variety of multivariate techniques that you can utilize in order to make adjustments for clustering depending on your study design. There are some special ethical considerations because again, you're randomizing practices and communities, but consent ideally ought to be obtained at the individual level. So there is again a fair bit of dispute and also some more specific guidelines with respect to what is sort of the appropriate approach to obtaining consent in cluster randomized RCTs. This is sort of an example. If you're going to add fluoride to the water supply in the intervention communities, who is sort of deciding and how do you obtain consent? Because of course, all the individuals in that community, if you're going to start adding fluoride to the water supply, will be affected. Are you gaining sort of consent at the individual level? Is there a mechanism that you can invoke in order to obtain that consent? And this is sort of a list of some additional resources and readings that you might want to consider. And there is more and more information that's sort of available. A lot of statistical work was actually done by Canadians. So Alan Donner from the Western University is probably one of the world-renowned experts in cluster RCTs. And then a lot of work was done by Campbell in England. So a lot of sort of references, a lot of publications are around those sort of two individuals. And thank you very much for attending. I hope this was useful. And I guess we have a few more minutes for questions. So please go ahead and ask any questions that you might have.
Thank you, Janusz. So everybody, I'm going to open up the audio now so that you can speak and ask your questions. But I just ask that you raise your hand, and then once I tab you, if you can unmute your audio so that there's no static. Okay. So let me just make that change, and then we'll go ahead. Okay. So. Sorry, anybody that has a question, feel free to either raise your hand or type out your question.
Well, I'm getting a lot of positive feedback that people liked it.
Okay, so
any questions yet?
So I see a question here from Catherine Nicholson. She says, I'm wondering if you had any recommendations to justify the importance of this methodology in funding applications to reviewers from your experience.
I think that ultimately it really has to do with what is sort of the research question and what is the hypothesis that you want to do. I'm always sort of defaulting that the way to sort of that your methodology should be the best methodology to answer the question that you want to answer. And if the question, for example, it's clear that you're going to deal with potential contamination, or that it really has to be sort of delivered in a way that sort of a larger unit is involved. I think that the opposite is probably the problem, where people would be saying, why don't you do a cluster RCT? Aren't you concerned about contamination? So I think that people, reviewers, are much more sophisticated nowadays, and they sort of recognize that this is an important issue, and that some interventions clearly require to be utilizing this methodology in order to provide rigorous evaluation and to provide good evidence.
So Janusz, I don't know if you saw Catherine's follow-up. She just said, yes, that's true. Thank you very much for the response. Okay, any other questions? Okay, well, seeing none, Janusz, thank you so much for taking the time today to present that very interesting presentation, and it was very informative, and I think the trainees would have gotten a lot out of it. And then for everybody, our next webinar, we don't have a date yet, but it will be in the fall, so there should be a couple of very interesting presentations that will take place then. So I will certainly be sending out the link, so make sure to watch for that. And then the webinar today is being recorded, so I will send out the link to the YouTube video where we will upload this webinar, okay? So thank you everybody for your time, and hope you have a great day and a great rest of your summer. Thank you, Janusz.
Well, thank you very much, everyone. Bye.